My name is Jeff Punch. I'm the director of the Transplant Center at the University of Michigan and also transplant surgeon. And I want to thank everyone for turning out this morning. It wasn't quite as warm as it was yesterday, but I think we're looking at a beautiful day in Detroit. Certainly a wonderful venue. I want to thank the International Association for Organ Donation for organizing this and doing this now for the third year in a row. Organ donation is something that is a passion of this group, and they are really leaders in our area for pushing the cause of organ donation in our area and the world. We have a distinguished group of people to talk today. I think it's going to be very interesting. The theme of barriers is something we came up with because it's something that doesn't really get addressed very much. We know that transplant's a wonderful thing, and we know that organ donation is a wonderful thing, but the sort of behind the scenes story is that not everyone benefits from organ transplantation and donation equally, and there is still a lot of work to be done in this area, and I think that the goal of this conference is to highlight the areas where we still have work to do, in addition to promoting the overall good of organ donation. So at this point, it's my pleasure to introduce the Executive Director of the International Association of Organ Donation, a very energetic guy who really brings it all together, Fouad Beydoun.
Good morning. Thank you, Dr. Punch, for the help you have been giving us for the past couple months. Thanks to your group. Also, I would like to thank our partners, Harper University Hospital, Henry Ford Hospital, the University of Michigan Transplant Department, Spectrum Hospital, Beaumont Hospital, St. John Hospital. Thanks to Dr. O. I hope I didn't miss anyone. I want to thank you all, and I would like to thank, bottom of my heart, Gift of Life of Michigan. I don't know if they're here today, but I hope they are. I want to thank Jennifer and Ramona Chapman. They've been with us for 3 years on this mission. And I would like to talk to you a little bit about next year and what's going to take place next year. We have decided to bring the conference as we want to take this conference to an international level now. It's time for it. And we have not spoken about the bone marrow. It's like something we all not discussed. We want to discuss. We want to bring that session. Also, we want to bring the cancer related to transplant next year. So next year is going to be, we will be a partner with the same partner we're doing, but we're going to bring people from Washington, D.C., from New York, from California, from the Middle East, from Europe also, to Michigan area. And that's what I meant when I said we want to take this conference to an international level. So it's going to be 2 days conference. It's going to be at the Ritz-Carlton, and the third day is going to be our banquet. Please note, it's going to be April 18, 19, and 20 at the Ritz-Carlton next year, and in Dearborn, Michigan. Also, I would like to thank our physicians. They came from all over United States, and I apologize not mentioning their names. I want to thank the Kidney Foundation also in Michigan. I want to thank Dr. Susan Morgan. I want to thank Dr. Mary Ganakos. She is presenting today from HRSA, and she's been supporting the organization since we started. Let me thank you all, and I would like to thank also again Dr. Jeffrey Punch, the head of the transplant at the U of M, the University Center. I want to thank you, and I want to welcome you again. Thank you.
Thank you, Fouad. It's now my pleasure to introduce Dr. Henry O. Dr. O is the director of the transplant program at St. John's Medical Center here in Detroit. He's one of the most respected and busiest transplant surgeons in our area. He's former president of Gift of Life Michigan, and he's going to moderate our first plenary session on barriers to recipient listing.
Thank you, Dr. Punch. Good morning. It is my privilege and honor to be the moderator of the first plenary session titled Barriers to Recipient Listing. Before I introduce the speakers of this session, I wanted to walk you through the process of being transplanted using the model of end-stage renal patient. The access to renal transplantation begins with the end-stage renal disease in patient who develop the end-stage renal disease. Sometimes they get the diagnosis late in their stage, so they're referred to the nephrologist quite late. And also they get educated about the choices of their treatment modalities, including kidney transplantation. And then they will be referred to transplant programs where we have some barriers from the nephrologist standpoint. Some of the nephrologists' belief really interferes or favors the transplantation, and that shows that non-compliance on the part of the patients or a cardiac status of the recipient candidates, or the HIV infections or any other communicable diseases, as well as the BMI of the patient, overweight problems, and then a poor outcome on some ethnic group of patient post-transplantation. As you all know, some patients do worse than the others after transplantation. From the patient preference standpoint, patient may refuse to undergo transplantation because they have some economic concerns, for example, disability and insurance. And for this part, we have a speaker as well this morning. And then some of the patients have a fear of unknown about the operations. And then there's mistrust among some ethnic group people for their medical services. And then language barrier. Some ethnic groups may have difficulty communicating with the medical professionals. And so then they have to go through the pre-transplant workup. Simply it takes too long and there are too many tests for them. And for example, getting a cardiac evaluation using the dye at times may put them into dialysis. So there is a lot of hesitation to go through cardiac evaluations. And then they get onto the list while they're waiting for kidney transplantation. On the waiting list, there are a few hurdles that we have to go through. Those people who are lucky enough to have living donors, they could go ahead and receive the living donor kidney transplantation. And also, there's an issue about the HLA disparity among different ethnic groups. And sensitization problems, somebody who has had previous transplants, blood transfusions, or pregnancies may have high antibody levels that will interfere with getting a negative cross-matched kidneys. And socioeconomic factors, some of the recipients who are waiting on the list may not have telephones, may not have the access to the transportation, so they may not show up to the hospital when they need it. So finally, they get to receive transplantation. Keep this in mind. I'd like to introduce the following speakers. The first speaker of this plenary session in the morning is Dr. Akinlolu Ojo. He's a professor of medicine, University of Michigan Health System. He's been well known throughout the transplant community that he has published numerous articles in the field of transplantation. And without further ado, I'd like to introduce Dr. Ojo to talk about the barriers to kidney transplantation in minorities. Thank you, Dr. Ojo.
Good morning, and thank you, Dr. O, for the kind introduction. I was asked to address the issue of minority barriers to listing for kidney transplantation and some of the ways in which those barriers can be overcome. And I think during the day you will hear from many of the distinguished speakers different aspects of these issues related to barrier. So what I would like to do is to walk through some of the areas where there are well-described limitations in access to getting on the waiting list as it affects minority populations in particular. And I want to start that by sharing with you the story of a patient. And I want to share this story with you because in what I do, most of the time, I'm not in the clinic seeing patients. I'm looking over large databases and data sets. And even though the data can give us a lot of information about what is going on, it never really completely tells the full story, and the full story has to come from the patient. And 2 days ago, on Tuesday, I walked into the transplant evaluation clinic to see my first patient, and this particular patient personifies all the aspects of issues related to barriers to getting on the waiting list for minority populations. The lady that I saw 2 days ago is a 49-year-old African-American female who had lupus and started dialysis 12 years ago somewhere in Indiana. I've taken out the specific names of places so that I don't violate patient confidentiality. And the patient was on dialysis for 12 years and came to us at the University of Michigan 2 days ago for transplant evaluation. When I saw the patient, I did my job of providing transplant evaluation, and I left the room. I went back, I did a dictation on the patient, and as I thought more about that particular patient, I wanted to get some information from the patient for this conference, so I went back to the room and I had about a 15-minute discussion with that patient. What I would like you to note is that this person, at the time that she started dialysis, was only 37 years of age. And she came to the transplant evaluation clinic with a 33-year-old daughter. The patient herself had her first child at the age of 16, and then another child at the age of 19, went back and got her GED, and then got an associate degree and got a full-time job. I make that point because this is somebody who is quite energetic, and as you can see from that life story, is a go-getter, if you will. I started asking the patient why she had never come forward for transplantation, and she said to me, well, you know, I was told that I was on the transplant waiting list, and I never got called. And I asked her whether she had ever been to a transplant center for evaluation, and she said no. I asked her, do you send blood specimen to your organ procurement organization? She said no. And the daughter who was in the room, and by the way, this lady moved to Michigan because her daughter, who had lived in Chicago, got a job at MSU and moved her mother in with her and started dialysis in Michigan in February, and is already getting transplant evaluation at this time. The daughter chimed in and said that, well, when her mother got sick, the doctor told them that she could not get a transplant because of lupus. And I asked her further, were you sick with lupus when you went on dialysis? She said that she was sick for about 6 months, then she got better. And the daughter kept asking the dialysis program, including the nephrologist, why her mother is not getting a transplant, and they kept telling them that she was not eligible for transplant because of lupus. I took that information and I left the patient, and that night I did an experiment. I went to the computer and I put myself in the role of that patient, and I started looking for information about lupus and kidney transplantation. I knew exactly where the information was, but I pretended that I didn't know anything about lupus and kidney transplantation, And it took me about 27 minutes to come across the National Kidney Foundation website. And if you read what I found on that website, quote for quote, it describes what can happen to a patient with lupus and how that patient can benefit from transplantation. If this patient had done the homework herself and had gone to the website, she would have taken 27 minutes to get this information. I knew where the information was because I've seen it before, and this patient would have been better served if she had access to this information. It takes a while to come across this type of information if you are not computer literate, and about 1/3 of patients who develop end-stage renal disease do not have a high school education and may not have access to a computer. I tell this story because there are multiple opportunities where this person could have gotten access to transplantation, and the barriers that limited are getting access to transplantation is based in the healthcare system, and part of it is also based in the patients themselves. The barriers that I will be talking to you about are those things that are not things that cannot be changed. If somebody is too sick, they can never get on the waiting list, or if there is evidence that they have a medical condition that will lead to death very quickly, those type of people will not be eligible for transplantation, and so those people are not considered to have barrier. How I define barrier for the purpose of this discussion are those things that we can measure. They are objective things, and they are obstacles that can be overcome, and I term them discretionary obstacles that we need to work on to improve access to the waiting list for those patients who need transplantation. And this is a very old, enduring, and vexing problem. One of my mentors, Dr. Held, did a study in the mid-1980s, and that study was published in one of the Internal Medicine Journal in 1987, and the title of that article was Access to Transplantation as the United States Eliminated Racial, Income, and Gender Disparities. This article and subsequent work led to a lot of national focus, and a lot of efforts have been undertaken over the last 20 years to try and improve the situation. But when Dr. Held wrote the particular article in 1987, at that time, if you look as depicted on this slide, the fraction or the percentages of patients of different ethnic group for those who are on the waiting list and those who got transplanted in 1 year, what you see, and I don't have a pointer to be able to point to this, but I will describe the bars to you. So the blue bar represents the percentage of patients for each ethnic group that were on the waiting list. And the yellow bar are those people who got a transplant in that year. And as you can see, for white patients, 64% were on the waiting list, but 76% got transplanted in that year. For black Americans, 30% were on the waiting list, 20% got transplanted, and the numbers for other race groups were much smaller. If you move forward in time to 2004, even though a lot of effort and energy had been directed to improving access for minority, the situation is the same. For white patients, 53% were on the waiting list, and they got 76% of transplant that year. For African Americans, there were a lot more people on the waiting list, but only 20% got transplant. Asians, the same story, and the numbers were too small for Native Americans. I do not think there's anybody who believes that minority groups are being singled out and discriminated against in trying to get access to the waiting list and getting transplant. But if we look closely at the process of getting on the waiting list, there are many key players and participants who are involved in that process. The patient